All right, good morning, everyone, and welcome to the second to last, actually it's a third to last installation of the NB Heart Center CV weekly rounds. There's probably a little bit of a hangover from the cath rounds this morning because we've had some good spirited discussion around cases and it's just completing itself. But I didn't want to delay the start of this particular session, which I'm super excited about. Dr. Rob Stevenson, who's been a cardiologist here at the New Brunswick Heart Center, has really been a spearhead for I would call it just good overall behavior as it relates to cardiovascular disease. Specifically in the realm of smoking, he has really taken the lead on this and really worked towards smoking cessation as a goal of his. And in his court has always been a Dr. Kerrie Luck, who recently completed her PhD and is now in the midst of completing her postdoc. And she's really a provincial expert in the realm of smoking and vaping, and informs a lot of important people to this effect. And then we have Dr. Alex Saunders, who's in the throes of her cardiology residency, and who we are excited to have join us sometime in 2024. Oh, so I'm just going to mute everyone just to make sure that we don't have any more. So Rob, I'm going to just where I've muted everyone, I'm going to get you to unmute yourself and kick off. And thank you so much for doing this. Off we go. So you just have to unmute yourself, Rob. So I'm just waiting for Rob to unmute himself. Obviously,
I think if you hover at the top, the commands are up there because they kind of disappear after you start a presentation. So they might be hiding at the top of the screen.
Myself, thank you,
Perfect.
Alex. I'm only as capable as those people that prop me up on a daily basis. So hopefully that still works. Can you see that? Okay, sorry for the delay. Obviously don't spend a lot of time on Zoom. Thanks for the opportunity. My job here is just to remind you how much Kerrie Luck has helped me with this file over the last, well, near decade now, and really none of what has happened in New Brunswick with tobacco would have happened without Kerrie's expertise and drive. She's really now an expert advisor to the provincial government and as a national expert in this field. So I've highlighted this slide just reminding us all, the smoke free together, we're all in this together. They did steal our motto. And my job here really is not to remind you all that tobacco is bad for us and that no one needs to smoke, but rather to remind us the sense of agency and urgency to continue on this in this journey. It's not going away, as I hope I can remind you in the next few slides. Looking back to 2013, we use this slide often to remind people that New Brunswick was in an unenviable position as the most tobacco-ridden province in the lower 10. We were close to 20% and served well above the national average. We had cited at the time that at least our goal should be to be on par with the Canadian average. Could we do any better than that? When we looked at 2017, after a number of interventions here in the province, we seemed to be faring a bit better. And for a moment in time, we seemed to fall below the national average. Having said that, I guess you can tell where I'm going. When we looked then at 2019, we were once again cited as the highest tobacco prevalence in the country. There are reasons for this, and Kerrie can certainly go into the depth and detail of the analysis. When we switched from CTADs to C10s, the counts were different. This is a small population, but it's consistent across the country. And for some reason, whatever it is that New Brunswickers and young New Brunswickers are saying, it's certainly making folks think that we've got a big tobacco problem here in the province. This brings us back really to the mantra, and anytime that I'm talking, this is my opportunity to remind you all of, Dr. Luck's position in this project. The why or the you is all of us. And if we as leaders, whether we're physicians, I know that cardiologists are a dime a dozen, and I'm reminded of that often. But us as physicians, as New Brunswick Heart Center health advocates, as nurses, healthcare providers, as pharmacists, as administrators, it really is our responsibility. And if we think that somebody else is going to look after this, it's simply not going to happen. Much of our education was to change the language and the normalization of tobacco use in New Brunswick. And historically, it was seen as a habit. It's anything but a habit. It's an addiction. And there was much that could be done to denormalize. For instance, not having pods of people smoking outside of every entrance of the New Brunswick Heart Center. That was certainly important. The support piece is key. To tell someone to stop smoking without providing support is nothing short of shame and ridicule. And the respect. This is not an easy project, and we do know that our efforts to help people to quit smoking is going to be addressing the needs of a chronic disease, and really, whether you're dealing with administrators that don't understand, whether you're dealing with governments that think that there are other priorities, or people that continue to use tobacco, you just have to love them through it. It's the only way. I'm going to highlight just quickly a recent handout provided by the Canadian Pharmacists Association. This is one that Kerrie's brought to my attention. Back to our Ask, Assist Advise, or Ask, Advise, and Act. The A's, there's 4 A's or there's 5 A's. Really what it does is reminds us that every time that we see a patient is our opportunity for an intervention. And there's really nothing more that we can do that affects their greater overall health and really longevity than helping someone to quit smoking. We use this slide, and really it's nice to see here highlighted that we're going beyond the standard, 1 patch per pack, and this algorithm will include the higher doses and guide us through the needs of patients. Basically, we can use as much nicotine as patients require. Looking into the third line alternatives, simply going to highlight here the use of cytosine. This is interesting, and it's a product that I do use when patients say they've tried everything. There's certainly great evidence and safety efficacy data for the use of nicotine replacement therapy, Wellbutrin, varenicline. And when patients have tried all that and absolutely refuse, I said, well, have you tried the natural health product known as Crave? The nice thing about Crave, and reviewed nicely here in the CMAJ a couple of years ago, is it's been around for 50 years. It's available widely in Australia, New Zealand, Japan, under different names like Tabex. When we launched here with our smoking cessation project back 6 or 7 years ago, people did ask me about Tabex. We weren't able to access it. Fortunately, the pharmacist, the Shoppers Drug Mart here in the North End on Lansdowne, does access it and brings it in so that we do have access to Crave. And for $50, we see near 50% quit rates with the use of Crave. I highlighted here, and really this is just a talk to remind us that there are options. And if we haven't thought of these things, then perhaps we should. You really can't talk about tobacco, and no one's going to let you just do a tobacco talk now. Much of the rage is in and around vaping, and I think our concerns are realistic, and that this affects the young population. And we realize that for many, this is going to be a step towards tobacco. A recent review of this, and to borrow on Ansar's question, is this an epidemic? Where is this going? This is almost a call to action for Chris White and his ECMO team, in that there was a rise in 2019 of ARDS associated with vape use, specifically THC solutions, and specifically THC solutions containing vitamin E acetate. And as it turns out, this is a bad thing to inhale. And all I'll do here is highlight that when you have an unregulated industry putting into these inhalation chambers what they think might make their product more appealing to users, then you end up with unnecessary deaths and the use of ECMO machines. I think I'll leave it at that. this, I think, is the most important thing that we can discuss, and that's the question of whether vaping will lead more people out of tobacco or lead more people into tobacco. And with the negotiations going on currently with big tobacco, make no mistake, behind vaping we have big tobacco. They're in essence negotiating with provincial governments to ensure that the access and use of vaping products are not significantly regulated because it makes it more difficult for them to get their products into the hands of users, often young users. Who better to start in your product than someone that's 15 or 16 years old? Sorry, but you put flavors in your solutions, and I know darn well that's who you're targeting. So we've wrestled with this, and you'll all remember the lovely debate that I had with Dr. Searles 3 or 4 years ago at the MB Heart Symposium, talking about the gateway. And at that time, we really didn't have great numbers to try and figure out whether more people were going to use electronic cigarettes as they're purported by all of these startup vape shops and big tobacco using products like the dual delivery systems. The question would be then, would more people use those products to quit, or would it unfortunately, or fortunately, depending on how you look at it, maybe that's been their ploy all along, to make a lot of noise up here about how it's going to help people quit, all the while knowing that every young person that they get introduced to these cool new vaping technologies would be someone that would be more likely to go on and eventually use tobacco. And that's exactly what you want, someone to use your product throughout their life and make their $20 donation to your company's profits on a daily basis for the next 60 years. So there was a great Cochrane review in October, which then suggested that we could probably see in society, when we look at nicotine replacement therapy versus nicotine replacement therapy by way of electronic cigarette, we would probably see that 4 more people out of 100 would be likely to, at 30 days, be not using tobacco. Unfortunately, when we look at the effects on our youth and look at high school students, where we see vape use in high school students as high as 33%, but ranging somewhere between 22 and 33%, realizing that electronic cigarette use with all of the flavors and all of the coolness that comes with it, the use, again, of ammonia chemistry with nicotine salts in the same way that they've done to make tobacco more palatable, and to have it be absorbed more quickly and more readily into the system to give you the fix that you need as fast as you can get it. What we see is this 3 to 4-fold increase in a population that is using, with a high prevalence of 20 to 33% use. We estimate then that we can see as many as 10 more people wandering through this gate into tobacco use at some point, say, in the next year. So if 4 have left and 10 have come in, I think it's probably a little bit like how Jeff Douglas feels in CCU right now, and that we have more people coming in than we have people going out. And I think that is the key message. It's a bi-directional gateway. And as much as they're going to tout the benefits of vaping for smoking cessation, I think that realistically, we should be fearing the concern that this simply provides access to tobacco for our youth. We know that people that would never try tobacco are more likely to try vapes. And we know that once they've tried vape, they're more likely to use tobacco. It's an unfortunate catalyst in this equation. And further, I think I'll end here, but really it's a mostly unregulated gateway. And I think there's no time like the present to imagine that if these vape shops were also selling unregulated vaccines, which may or may not help you against, any virus, it might be C19, it might be C22, whatever they promote in their placards outside of their shops, it's so much easier to do so without regulation. You can certainly frequently get your latest Pfizer products here. And that's in essence what we've done. We've seen that these shops have been able to open with very little regulation, and that they continue to be very, very profitable. So in my midway conclusions, I'll remind us all that tobacco is the new tobacco. We don't need anything else to replace this. And really, with an unregulated gate on cigs and vapes, we just have to remind ourselves that gate swings both ways. And so I'm going to hand over to Alex now, who I think can unmute herself and be ready to go.
Great. And then if you want, as I said, I can share on my screen pretty quickly, I think, if you give me just a hot sec.
I'll stop my share. Maybe it's gone already. She's got hers up. Are you good to go?
Yeah, we're good to go. There we go. So hi, everyone. I'm Alex. I did my internal medicine training with you guys, and looking forward to hopefully coming back at the end of all this. So disclosures, I have none. Still a very, very poor resident. So I'll quickly talk just about cannabis and the pathophysiology changes that have come with the pandemic, and then obviously what we're all here for, which is the cardiovascular implications of all this. So first is to talk about, we know the cannabis has a lot of different chemical compounds in it, the key ones being the ones that we've all heard of, which is THC and CBD. There's over 700 different ones though, and there's 3 strains of the marijuana plant. There's cannabis sativa, which is the most common one because it has the most THC, which produces the euphoric effect and the psychotropic effects that people kind of go for. But there's also indica and ruderalis, which have varying concentrations of all the cannabinoids. And so we discovered that cannabis and that our own bodies have all of these cannabinoid receptors, which is why the use makes so much sense for people. So there's CB1, and as you can see throughout this diagram, it's concentrated mostly in the brain, but also at various spots throughout the body. And then CB2 was discovered as a second receptor in 1993. And so as you can see on the side here, the receptors communicate with our body's natural neurotransmitters, and the cannabinoids are already kind of a natural part of our receptor system. But obviously, when there's more of these in the mix, then more of that stuff happens. And so now to talk about the pathophysiology and why do we care about these receptors and what they do in the body? And so if we look at the heart and we look at how these cannabinoids, if we kind of go back to the previous slide, you can see that there are certainly some that were in the middle here. And so that's the ones that we're going to talk about. So the CB1 receptors, these are the ones that are mostly affected by THC. So those are the ones that are in red, whereas CBD is mostly CB receptor number 2. And so looking at the pathway of CB1, as you can see, a lot of these have been, as it's activated, it triggers cell death and adverse tissue remodeling. So a lot of the red areas are tissue injury and endothelial damage. So as you can see, there's vasoconstriction, hypotension, increase in heart rate. And this is all done through several pathways, which we won't necessarily get into today because that's not the point of today's talk. But at the end of the day, all the stuff in red is what's kind of looking like the start of damage to the heart muscles and to the myocytes. Whereas blue, interestingly, maybe doesn't have as much damage, though unfortunately, whenever you get CBD oil, you can't get it without THC. There's always a little bit of contamination. So even if you think you're just getting the good stuff, there is usually still a little bit of the red stuff in the mix. And so these are the cannabis formulations. We all know cannabis is smoked, but there's also many other ways to use cannabis. It can be used topically, rectally, if you so wish, sublingually, and even with the smoking, there's also different variations like smoking or vaping, and they all come in different types. And so what's in our cannabis NB stores right now, from what I understand, is that there's plant-based and some edibles now that edibles have been legalized, so to speak. But there's also a lot of other synthetic forms that aren't so far in the stores, and these aren't used as much here. So if we go to what's most commonly used in Canada, most commonly it's smoked. There are edibles as well, like lollipops and things like that. There's e-cigarettes and vaporizers. And so when I was looking through this presentation, I kind of had to familiarize myself with what the difference between e-cigarettes and vaporizers were, because I didn't really realize that there was a difference. So if you look through, there's kind of a hierarchy of how these things were developed over the years. And so at first it was just disposable e-cigarettes. And then there were these pens, like the cartridges. So I see these being used pretty often, but now more and more I'm seeing people walking around with these boxes and pod looking things. And so these are what we mean when we're talking about vaporizing. And then the content of THC, not just in the smoked form, but also in the vaporizers, the content of THC has increased. And so if people talk about smoking marijuana a lot, like in the 70s, 80s, a lot of that, if you can kind of picture this going down even further, the THC concentration in that was quite a bit lower than it is now. The concentration again now would be up to 12.55%, which means that both the euphoric effects, the high that you get is more potent than it was in the past. And so I went on to cannabis in Canada. There was a recent survey now that cannabis has been legalized. They just finished their first round of numbers on Statistics Canada. And so this is about the use of marijuana in the last 3 months, and then the percentages per group. So if you look at everyone in Canada, in the last 3 months, this is pre-legalization, post-legalization. As you can see, the use of it has gone up, which is, I guess, not unexpected when you make something more accessible. In the age groups, it shows that the increases have all been pretty large, and in the age groups that we kind of care about as well, especially people that can have heart disease, as you can see, a fair chunk has increased. And then once again, New Brunswick overachieving in kind of all the wrong ways. Prior to legalization, we were kind of on par with everyone else, and though post-legalization, I guess everyone else has gone up as well, but we've gone up a significant amount. But I guess we could always laugh at Nova Scotia, but and this is just a diagram from that statistical report that showed the territories, because unfortunately they surveyed all of the provinces in full, but all they did with the territories was survey the capital cities, which isn't super helpful. So kind of as per usual, unfortunately, the territory is underserved, which is a whole other talk. And then when they went through the data on this as well, they looked to see the percentage of time that people had reported, like how much of the day that they were stoned or high, which was kind of interesting. So 37% of people said that they would be stoned or high on a typical day for 1 or 2 hours. And then 30% were less than an hour, but 8% and 9% were more than 5 hours of the day spent high. And so now, how has this all been affected by the COVID-19 pandemic? Canadians who report lower self-perceived mental health during COVID-19 were more likely to use alcohol, cannabis, and tobacco, which is not unsurprising. Looking at the Wave 1 data, there's an increase in both marijuana use and tobacco use, although more with marijuana use. And then prior to the pandemic, these were kind of our stats before that, so all of that increased just slightly. And this is just a diagram kind of outlining that same thing. And so now looking at the COVID-19 pandemic, I actually went and there's data, Stats Canada has so much stuff if you kind of dig through it, it showed the quarterly expenditures in dollars for alcohol, tobacco, and marijuana, like per household. And so it showed that obviously alcohol is still the most popular, but both tobacco and cannabis did show a spending of more money during that time. So now what are some cardiovascular implications? This is an interesting study done in the UK, a study of about 3,500 people. And what they did was they took users and non-users of marijuana. So about a third were users and the rest were non-users. And they just put them through a cardiac MRI and looked to see if there are any major differences. And interestingly, they found that people who were frequent marijuana users had enlarged ventricles, enlarged ventricle mass, and reduced circumferential strain, showing that the function of their heart was impacted, and there was some remodeling that is already starting to occur, and this was without having heart disease yet. And so some cardiovascular implications that do happen are listed here. So as you can see, it's there's been several. Now that marijuana is legalized, it gives us an opportunity to study it a little bit more. But we can see that there's a whole bunch of potential downstream effects that marijuana can have. And so are they better than cigarettes? This is an interesting study in the American Journal of Drug and Alcohol Abuse that showed that, so TUD means tobacco use disorder, which is a good name for it, I guess, and showed that if you can see, these were people that used marijuana and not marijuana. So kind of compared to, a lot of people will say like, oh, well, a lot of the bad effects from marijuana are just because the people smoke cigarettes, but it actually even looked at the group of people who don't smoke cigarettes, the percentages still go up. And it looks like the people who don't smoke cigarettes already, they get a bigger bang for their buck with regards to developing heart disease, strokes, which is not great. And then is it better to vape? Probably not. There's an interesting study that was just presented at the American Heart Association conference and just this November called the JIVE study. And so it evaluated endothelial function and blood pressure in healthy young adults who were both non-smokers, traditional smokers, and then vapors using this magical jewel something. They always have these very fancy sounding names. So it showed that it was associated with higher blood pressures, even in these young people. And then there's decreased endothelial function just with the use. So things that I hope that would be answered by the end were, is smoking harmful? Have we seen an increase in use since legalization? What about with COVID? And is marijuana safer than tobacco? So here's some references, and then I guess I can hand it back over to the team for question period.
Alex, thanks so much. That was fantastic. And thank you, Rob. And I know Kerrie obviously didn't have a chance to present, but your contribution is recognized. And I'd love to be able to circulate your guys' contact information to the group. I know Rob sent a pathway earlier just prior to round starting, but I think people would have a ton of questions on this front. This affects all of us, whether it be personally, professionally, et cetera, et cetera. And I think this is a topic that truly is, as I referred to earlier, is an epidemic that's growing. I guess, we only have a couple of minutes. So once again, if you can send your contact around, that would be great. And Rob, you can just respond to the email and send it around if you see fit. The second thing is so I often get asked, in patients who are undergoing cardiac surgery, who obviously have known cardiac disease. So this is not even a de novo population, who's in that 18 to 24 category. These are people with known cardiac disease who say, look, can I go back to using cannabis? Obviously we tend to take a hard line with respect to tobacco because we know the effects of tobacco. Cannabis, relatively speaking, and vaping for that matter, is so unstudied, and we're now starting to see more stuff out there, as you guys have shown us. But in your estimation, what is the advice that we should be giving our cardiac surgical patients, or even our non-cardiac surgical cardiac patients, about the ongoing use of cannabis?
Alex, go ahead.
Yeah, sure. When patients have been asking me that lately, and we actually just on the CCU that I'm working in have quite a few people who are frequent users. Looking through the data, the suggestions that we make are that they should not go back to using it. And this is kind of the same thing that we say with tobacco, is that obviously cutting down is better than the 2 packs a day you were smoking before, but obviously the best thing is not at all. There's not a lot of great evidence to say whether smoking is better than edibles, because edibles still do have the THC risk. But I guess if you were going to use any marijuana at all, I would suggest like using the just CBD, knowing that it's contaminated with THC as well, but at least on a lower amount, and then eating it instead of smoking it.
Excellent advice. Love it. What about cannabis withdrawal? I mean, once again, it's hard to know because people rarely quantify for you. We've always had pack years of smoking, and we've kind of used that as a metric for a burden of smoking disease. But what about with cannabis? What's your perception on that? And do you ever worry about withdrawal in that population?
I know that the withdrawal is that we see with cannabis is often from the tobacco that's put in with the cannabis. So often it's still like a nicotine withdrawal. So I've found that patients that have used cannabis, that the nicotine patches usually work to help with that part, because it's still a nicotine problem. For those that do like vape it or eat it, I haven't seen as much withdrawal per se, but a lot of people who have problems, who have cyclic vomiting from their marijuana smoking, and then just need to have a hot shower rather than having more marijuana. So usually I find that during their stay that they're not having troubles with their marijuana cravings.
Yeah, excellent. And then last but not least, Rob, for you, I think, what's your assessment? I mean, as far as, how we manage smoking in our patient population. I mean, obviously you've got a huge outpatient population, but even in the hospital, Do you feel like we're doing enough, or is there still a lot of ground to be gained on that front?
Well, I think it's ironic that we're happy to ticket people for not wearing their masks, but though there's, it was, I think, legislation in 2017 that actually made it illegal to smoke on public property, including hospital grounds. We've seen it creep back, and that's what we're always going to see with tobacco, is that creep back to trying to bring it back in, make it more accessible and more normal for people to join outside the doors and smoke. We've seen it more at nights here on hospital grounds, and it's as though the pandemic has made it okay because everybody's so stressed with the pandemic that surely it's okay to smoke again. And I think that we're going to have to see a wave once things have settled with that. We need to remind ourselves to go back to first principles, and that there's one thing that's going to kill more New Brunswickers than anything else, and it's not going to be the virus. It's going to be the ravages of tobacco across our population. So we need to swing back with that. And in hospital, I think we've seen a great rollout of the Ottawa model. And I think people are quite comfortable with that now. I've circulated that Canadian pharmacist guideline to remind us of how it should look, because it's every day. And I think everybody had talked about it. We've seen the people that were easy to help quit. We've already helped those people, and the people that we're seeing, 15 years in now are the people that are having more difficulty over time, or the recidivism of the disease. They've come back to it. And so we've got the low-hanging fruit, and now we're having to climb up that tree to continue to work at the important to make that important difference for people that are struggling. Perhaps not as easy as it was, but I do think that we have the programs in place to help support it, and we just have to redouble our efforts and remind ourselves that it's really nothing more important and nothing more cost effective for us to do than to help people quit smoking.
Rob, thank you so much. And thank you also to Kerrie and Alex, of course, for your presentation. Very valuable, and hopefully was useful to the people in the audience. As I can tell, so many people are still on. That implies that people are interested and take the subject to heart. No pun intended. Next week, we have Dr. Greg Hirsch from the QE2 Health Sciences Center, former head of the cardiac surgery program there, who will be talking specifically on the subject of frailty and when do we say no to patients on the basis of how frail they are. So that should be an exciting topic with an excellent speaker. Everyone, thank you so much. Have a great day, and we'll see you all next week.